Right, so this case is regarding a 70-year-old gentleman who came in complaining of some mild fatigue as well as some periodic right upper quadrant pain with radiation to the right shoulder. He has a known past medical history of cirrhosis secondary to chronic viral hepatitis, which I'll tell you more about in a minute, GERD, hypertension, and peripheral neuropathy. He is a former smoker, but quit about 25 years ago, has a distant history of alcohol usage, as well as IV drug usage, is retired from work as an engineer, lives alone, and of note, his longtime partner died of liver cancer about 1 year prior to his own diagnosis. So he had evidently had a liver biopsy in 1991, which had not shown any scarring or fibrosis. It's unclear exactly why he had this, but he says that he had had regular screening until 2019. He's diagnosed with hepatitis C in 2014, treated with Epclusa in 2017, since when there has been no HCV viral load found. Chronic and active hepatitis B was diagnosed in 2017, but HBV DNA has consistently been below, it's detectable, but below the limit of detection. And he was noted to have F4 fibrosis in April of 2017 and given a diagnosis of cirrhosis with Child-Pugh class A, 5 points. CT abdomen of note was done in May 2019 as a result of an ultrasound for screening, and that showed an indeterminate 4.2 centimeter right-sided liver lesion. And then he had an MRI, which showed a 4.2 by 2.5 centimeter heterogeneous lesion, which was thought to be a hemangioma, as were several smaller lesions. He was advised to get a repeat MRI of the abdomen for surveillance in about 6 months, but he was unfortunately lost to follow-up. He reestablished care with GI in February of 2021, at which time the ultrasound of the liver showed enlargement of his mass to 9.3 centimeters, along with 3 other similar appearing hypoechoic lesions in the right lobe. I won't spend too much time on labs, but essentially some baseline thrombocytopenia, as well as moderately elevated transaminases and alkaline phosphatase. AFP was mildly elevated to 7.5, and synthetic function was preserved with normal INR and albumin, and hepatitis status was as discussed before. He had an EGD in April, which showed no gastric or esophageal varices, and did show some mild portal hypertensive gastropathy throughout the stomach. He had an MRI of the abdomen in March, and it demonstrated multiple left and right-sided lesions, the largest being 9.5 centimeters on the right, 1.9 centimeters on the left, and it was overall consistent with multifocal hepatocellular carcinoma with possible hemorrhagic component. Here I've placed the axial T2 sequences, just showing the evidence of arterial enhancement as well as peripheral enhancement at 20 seconds. And then after 5 minutes, you can see that there is washout of gadolinium contrast. CT was done to complete staging and demonstrated multifocal upper abdominal lymphadenopathy involving the paraesophageal, paragastric, and portahepatis nodes. So he was given a AJCC 8th edition clinical stage 4A with CT3N1 disease with regional lymph node involvement, and as such was deemed Barcelona stage C. So questions for the panel would be, what systemic therapy would you consider using for this patient? Would you have considered TACE for this patient? And would you have been comfortable using Avastin, in theory, not in this patient, but in general, with a platelet count of less than 50,000? And that's something that's come up clinically.
So I think we can start with Dr. Barad. What are your thoughts on this patient?
Yeah, so I mean, now first-line therapies give you atezolizumab and bevacizumab as a level 1 evidence option. Obviously, applying it to patients in the clinic is a different story, because this patients that were in the study were more robust, didn't have the kinds of concerns you would see in the clinic, like varices or low platelets. But you just always have to take the clinical context into account. So I would at least give it a try with the understanding that you could have a bleed. And if you do, maybe you don't want to re-challenge them, but the risk of dying from the disease is far higher than the risk of an adverse event. TACE, I guess when patients are this advanced, what would be the true benefit? It's going to be something of diminishing returns, a procedure you can do because you can technically do it. I hope, like other malignancies, that once patients are deemed to be quite advanced, that really the focus is on systemic therapy.
Dr. Klubuka, what are your thoughts on TACE? The patients who have systemic disease, there are ongoing studies looking at combination of systemic therapy with locoregional therapies. If you had seen this patient in this situation, would you have considered TACE?
Yeah, it's an area, as discussed, that we don't have good data yet. We're looking at, combining with systemic therapies for those who are in stage C of the BCLC algorithm. But as far as, meaningful impact on life expectancy, you're really looking at something limited. You can always, of course, consider locoregional therapies in settings of palliation for pain or other symptoms. Pertinent to that, this patient does have a pretty preserved liver function as a child's A5 cirrhotic. So he would certainly tolerate a locoregional therapy. But again, the bottom line is for somebody with multifocal disease, including extrahepatic disease, you're not going to derive much benefit outside of perhaps pain control in a palliative setting.
Thank you. And I see Dr. Renz is on. What are your thoughts? Would you offer some radiation SBRT to this patient, maybe in addition to the atezolizumab and bevacizumab, or would you want us to just proceed with systemic therapy?
Yeah, I think for this particular patient, the systemic therapy would be the most important. There's actually some toxicity data associated with the VEGF inhibitors and SBRT doses, so we would have to kind of hold that therapy to do any kind of sort of SBRT like radiation. So I would kind of defer more to the systemic therapy and reserve SBRT for more palliation if after progression.
Sounds good. Thank you. Okay, so Dr. Helfand, we can continue.
Okay, very good. Well, thank you, everyone. So for our patient, he was started on Viriad for prophylaxis of hepatitis B reactivation in anticipation of starting immunotherapy. He was started on methadone and oxycodone for pain control, and he started, as per IM Brave 150, he started cycle 1 of atezolizumab and bevacizumab in April of 2021. He has tolerated it very well. In terms of toxicity, he has had some grade 1 thrombocytopenia, increased creatinine, nausea, and chills, as well as some grade 2 fatigue and peripheral edema, which resolved with diuresis. Restaging MRI in July showed grossly stable multifocal liver disease with increased central necrosis, suggestive of treatment response, as well as improvement in his abdominal lymphadenopathy. He's now completed 9 cycles of treatment and is doing quite well. So I'm just going to go over first-line systemic therapy for advanced HCC. This is a flow chart that one of the earlier presenters had shown, and our patient would have been placed in the BCLC stage C group, for which there are now a number of first-line options. And this graph, if anyone wants to look at the slides later, provides a nice view of some of the ongoing trials in each of these settings. These are the NCCN guidelines regarding therapy, and as you can see, we chose the atezolizumab and bevacizumab regimen, but other category 1 options certainly would have included sorafenib and lenvatinib. So in terms of systemic therapy, IM Brave 150, as Dr. Manga discussed earlier, essentially was a trial of about 336 patients, which assigned patients to atezo-bev 2-to-1 versus sorafenib with a co-primary endpoint of overall survival and progression-free survival. It was a very high-risk population, 75% of whom had macrovascular invasion or extrahepatic disease like our patient. These graphs demonstrate that there was a significant overall survival benefit as well as a PFS benefit. And as of the updated results from last year, there was a finding of a median OS at this 20-month follow-up of 19.2 versus 13.4 months. This just shows the superior quality of life found with atezo-bev versus sorafenib. Objective response was impressive with roughly in the HCC specific RECIST criteria, 33% versus 13.3% objective response in the experimental arm. Adverse events were typical for these two drugs, focusing on immune-related toxicity with notable hypertension in both groups, increase in liver enzymes in both groups, diarrhea much more notable in the sorafenib arm, as well as hand-foot syndrome seen in the sorafenib arm, but not in the atezolizumab and bevacizumab arm. Similar rates of grade 3 and 4 events. There were I believe 4 significant bleeds in the atezolizumab bevacizumab group, 3 of which were GI bleeds. SHARP trial had been published in 2008 discussing sorafenib in advanced HCC, studying 602 patients, looking at similar co-primary endpoints of overall survival and time to symptomatic progression, also with a high-risk population that was fairly similar to that of IM Brave 150, though with slightly fewer patients with extrahepatic disease. Like the IM Brave 150 trial, only patients with child PUA were studied. And in this trial, there was a survival benefit found of 10.7 versus 7.9 months of median survival. Events as seen in all of these sorafenib trials showed notable hand-foot syndrome in the sorafenib arm, as well as diarrhea, and benefit with sorafenib was seen fairly consistently across the subgroups, as you can see on the left, perhaps with the exception of those with extrahepatic disease. The REFLECT trial was a non-inferiority trial of lenvatinib compared to sorafenib, and included 954 patients with fairly high risk disease, and found non-significant differences in lenvatinib versus sorafenib, 13.6 months versus 12.3 months median overall survival, which was statistically non-inferior but not superior. And PFS was superior in the lenvatinib arm. The objective response notably was significantly higher in the lenvatinib arm at 24.1% versus 9.2%. This was statistically significant. In terms of toxicity, significant toxicity, as we often see with TKIs, was present in both groups, though the incidence of grade 3 hand-foot was much higher in the sorafenib group at 11% versus 3%. And in terms of hypertension, there was more hypertension of grade 3 or above in the lenvatinib group, of 23% in lenvatinib group versus 14% in the sorafenib group. The Checkmate 459 trial, which has not actually been formally published and peer-reviewed, but has been presented at ESMO, studied the use of nivolumab 1:1 versus sorafenib with a primary endpoint of overall survival. Inclusion criteria was ECOG 0 to 1 along with child PUA disease, so there were 5% of patients who did have child PUB disease. Median OS with a follow-up of 22.8 months was 16.4 months in the Nivo arm versus 14.7 months in the sorafenib arm, which did not meet the predefined threshold for significance. The results were very similar at 33.6 months follow-up, published last year. OS of about 60% versus 55%, and at 33 months now, almost 3 years out, 29% survival in the Nivo arm versus 21%. And while no significant difference in overall survival was reported, there was a fairly significant difference in grade 3 and 4 adverse events, with 22% reported in the Nivo arm versus 49% in the sorafenib arm, which is consistent with the use of sorafenib in the past and the known toxicity profile of nivolumab in many other malignancies. There was half the rate of discontinuation in the Nivo arm. So this is just a summary slide looking at the median overall survival across all of these trials. And essentially what we see is that across all of these trials for sorafenib in the first line leads to a median overall survival of approximately 10 to 14 months, and that the best data yet would be in the IM Brave 150 trial, which with an updated 15.6 median months of survival, median follow-up, has a median overall survival of 19.2 months. The data in the REFLECT trial confirms that lenvatinib is non-inferior to sorafenib with a more tolerable toxicity profile. So thank you very much, and I'll be happy to take any questions.